Let us start with a land acknowledgement. So we are in or at least our health ethics team is sort of grounded in the London area. So this is a land acknowledgement that comes from there, although I recognise that we are, as a group here, scattered through the province. So the health ethics team acknowledges that we are gathered today on the traditional lands of the Anishinaabeg, Haudenosaunee, Luna Piwak and Atawandoran peoples. We acknowledge all the treaties that are specific to our area. This land continues to be home to diverse Indigenous people, First Nations, Métis and Inuit, whom we recognise as contemporary stewards of the land and vital contributors to society. This land acknowledgement is a tiny step towards reconciliation. Awareness means nothing without action. It is important that everyone takes the necessary steps towards decolonising practices. We encourage everyone to be informed about the traditional lands, treaties, history and cultures of the Indigenous people local to their region. So let me talk about that for a minute. I was on a call last week with one of the hospitals that we work with, and the sort of quick and dirty version of the story is that there was an interaction between the spouse of a patient and a member of staff, and the interaction, what do I say next? How do you describe the interaction? The descriptions of the interaction are completely different if you take the story as told by the spouse of the patient and the story as told by it was a nurse, the healthcare provider that was engaged in that interaction. Both parties intend to work together perfectly well. So there's no intention of any sort, but the descriptions of the events that occurred, and it included a touching. The descriptions of the things that occurred are completely different. So the spouse of the patient has an Indigenous background, and she said that from her perspective, the situation was one where it was oppressive, that the healthcare provider had acted in a way that was, I think oppressive is the right word, that it exerted power, that demonstrated the authority of healthcare and healthcare providers, and that marginalized her, made her feel terrible when what she was doing was trying to defend and protect her partner. The other side, the healthcare provider, says, no, that's not what happened. What happened was there was a touching, and I said, don't touch me. Go on. Can you give me a nod there? What I'm after is that the same, I would say, completely innocent interaction is perceived in radically different ways by the two parties to that interaction. So then the challenge of reconciliation is, well, what do you do next? So typically when you're faced with a complaint, what you try to do is adjudicate the complaint. You try to work out whether the complaint is well founded, whether somebody has done something wrong, in which case they should issue an apology, or whatever it is that goes next. But typically that adjudication process, I don't know, it's got a winner and a loser. Is that the right way of putting it? You adjudicate and you say, yes, this is well-founded, or no, this is not well-founded, and then you move on from there. I don't know that that's the right approach here. What the spouse of that patient was indicating is, she's responding to, I don't know, hundreds of years of systemic oppression. And how do we respond to her response? And I haven't got an answer. I don't want to say, well, this is what we should do. I just want to say that this is really hard. And I think the way we have to go forward, I mean, I think the next step is something like we've got to give up power. We have to not adjudicate. I mean, I don't know if that's right, but we have to acknowledge that this is the way this was received. This is the way this was felt, and that's what we have to deal with. And we unintentionally, with the best intentions, created that impression or allowed that impression to occur, and that means we have to step back. Now, I don't know how to do that well. I mean, can you give me a nod? Can you just acknowledge that we can stick these statements about reconciliation up? They don't mean very much. What do they mean in practice? And I think what I'm trying to capture is that they mean something serious in practice, and that's got to include something like a stepping away from judgment, stepping away from adjudication. You're right, they're right. Back towards something like sorry, yeah, and a relinquishing of power. Go on, I got some thumbs up. Does that make sense to you? It's just, I don't know how we do this in practice. I just want to acknowledge that I think it's really hard. Okay, let's go. Good. Yeah, we're thinking here. Excellent. Let's go to the next one. Oh, let me tell you who we got on today. I mentioned it. So my name is Rob. Many of you I would have met, some of you I would not have met. So our little team is based in London. We've got on the line Lockie, who'll give you a wave. You may detect a similarity in the surnames of the people that are on this list. Lockie is a dearly beloved son. And I got to tell you that it's really weird to work with a kid, your kid, as a person. He should smile at that. I mean, because normally he's a kid, right? But Lockie is he's doing doing his PhD. You should do this. Go on, Lockie. Tell us who you are, what you're doing.
Sure. Can you hear me okay?
Yeah, come closer because you're a bit quiet.
All right. Yeah, so I'm Lockie Butcher. As Rob mentioned, I'm doing my PhD in ethics and public affairs at Carleton University, with the focus of my dissertation being on the expansion of MAID to include mental disorders as the sole underlying medical condition. We will be talking about, in later sessions, end of life stuff. And so if you have any questions about MAID and mental disorders, I would be happy to have a conversation about that then. Or if you have questions before then, feel free to ask. On top of that, I'm also completing an ethics fellowship at London Health Science Centre. So that's a little bit about myself. Back to you, Rob.
Thanks, Lucky. We haven't got Evan with us today. We've got Aurelia, who, again, you can see this surname cropping up. Aurelia, are you going to say hi?
Hi, who is trying to juggle the things that are not always very cooperative.
And she's hiding. You have to shift your camera a little bit or your face. So there she is. So if you've been connecting or sort of trying to connect, you would have been talking to Aurelia there. So please use the chat. Tell us who you are. Maybe let us know what your organization is, what your role is within that organization, and we'd be really interested to know why you're here. Why are you giving up a Thursday evening to spend time with this crew? So please, use the chat, put something in there, and let us know what you're thinking. Let us know what you want. You could also you could put into the chat what you hope to achieve. So, I mean, that could be, is there a particular topic that you want us to talk about or think about? Please, put those in. Give us some bit of a feedback. And Lockie, I'll get you to monitor that chat, and in a couple of slides, I'll come back and you can tell us what people are saying. So if we can go on to the next one. This is a little map of where we're going. We're going to do 4 sessions. We're going to go for about an hour and a half each time. This first one is ethics. We could do this in a intro to ethics class. So I think we're gonna look at fundamental ethical theories, the attempts to answer the question, what makes right acts right? We'll come to that. That will sort of that'll be the end of our session today. And then what we're going to do is do ethics through the life cycle. So imagine you take a person's life, and then we're going to chunk it up into three bits: the beginning, the middle, and the end. Go on, you guessed that, didn't you? And what we'll try to do is unpack the ethical puzzles, challenges that arise at the beginning of a person's life, and then we'll do ethics for grown-ups. So ethics for people like us, and then we'll do ethics at the end. So ethics at the end of a person's life. So that will be, the death and dying piece. That's the plan. Okay, we go to the next one. Go on, Lockie. Do you want to tell us what we've been seeing here?
Yeah, so we have a bit of a spread of both where people are from and what they do. So we have some individuals, Richard's from Skokie, Algonquin, Sarah Spice is from Huron-Perth Healthcare Alliance, some people in Niagara region as well. I'm seeing Tilsonburg, and it's a wide spread of what people are, of what their background is and why they're choosing to get into this, which is nice. So I'm seeing some social work, I'm seeing some psychology. Some people are happy to admit that they're interested in ethics and they're looking for that continuing medical education credits, but hearing just general interest in ethics and looking to support some of their day-to-day work with some of the things that we'll be talking about.
Oh, look, thank you. I'm just seeing them as they sort of flop up, crop up, and then disappear. And we have got it looks like a great range of different healthcare professionals. Let me sort of tease you with this just a bit. I would say that all of you picked the healthcare professions that you did because of who you are. So if we had you in a room, I don't know, we could ask a few questions and we'd be able to identify the social workers. There'll be the sort of, you don't become a social worker without having, I don't know, a particular set of characteristics. And we'd get something different from different nursing specialties, and something different again from some of the people who've come in through a technological route. So one of the fun things that I hope we'll be able to do is to look at the ways in which our different personal and professional perspectives shape the way in which we look at things. And of course, throughout all of that, we're going to be identifying that we do better when we can, what's the right word? When we can air those different perspectives. We do better when we conceive from different points of view. All right, so we're going to do a word cloud. So this is partly because I don't have a good definition. So if I say the word, or the 2 words, health ethics, or the phrase health ethics, what do you say? And what we're going to try and do, we'll do the little word cloud, and we'll keep that in the chat. It will sort of try to cluster the ideas that that you're thinking about as we come at this topic. Should we go on to the next one? Oh, controversial, somebody's put in there. Yes, whoever that was, I just got that one word. The stuff that we're going to be doing is controversial. I mean, I think that is exactly right. Okay, so before we get to this slide, I'm going to take a little step back, and I want to do personal ethics and professional ethics. So I told you I was with a group of long-term care directors of care this morning, management teams from long-term care. And one of the pieces that keeps cropping up and that I have to remind myself to do is we often come at ethics, or the word ethics, or the topic sits there big and heavy. It's a sort of, I don't know, a lurking spectre. And of course, what I want to try and do is to say, let's demystify it. Let's make it ordinary. Let's ditch the heaviness that comes with thinking about ethics as ethics, and let's try to connect those ideas, those words, with the things that we actually live. So I'm going to start with personal ethics. Now, those of you that I know, that know me, may have heard this story before, but I'm going to do it anyway. So forgive me if you've heard it, because I want to try and capture what we're talking about in its essence when we talk about ethics. So we're going to do My Life, the video, the deathbed scene. So I can't see your faces. I can't see many faces. You've got a script. Your Life, the video, the end, deathbed scene. So you can start by thinking about great movie deathbed scenes. I'll date myself, but you can guess that anyway. Thelma and Louise is one of the great movie deathbed scenes. It's not a bed, it's a car going off a cliff, but it's an end of life scene that is pretty memorable. I've still got an image of Madonna's version of Evita, where she's lying in state in the palace and all of Argentina is outside singing. So do yours. What does your deathbed scene look like? Mine is a deathbed scene. So it really is, Rob in the bed, surrounded by his grieving family. You got the grieving part, right? His adult grandchildren are clustered around the bed, and they're saying things like, we're gonna miss Rob for his, or grandfather, for his wit and his wisdom, and probably for his wine cellar. We're going to come out of that deathbed, that room. We're going to go into the office. You're in the office there with Aurelia. Past, on the shelf, the collected works of Butcher. Let's just say there's still some work to do on that topic. I was in an academic environment for so long that it got sort of ingrained in me that the way in which you contribute to your profession is by writing. So collected works of Butcher. There's a helicopter shot of the estate. Did I tell you about the British racing green Jag that's parked by the tasteful fountain? Anyway, have a bit of fun with yours. What does yours look like? And then what you do is you unpack that scene in terms of the values that are represented there. So it's a family scene, pretty clear what that value is. There's a value of connectedness to family there. They're grieving. That means that I'm relevant to them, right? They're grieving the loss that they will have because my presence, it's my story, so I can tell it how I like. My presence is something that is significant and that they will miss. I've got adult grandchildren. That means I'm old. But probably just age isn't the value. There's no point in living to a number. There's probably something embedded in there around, there's probably a health idea in there that I want to be, to live a life that allows me to do the things that I want to do for an extended period of time into my old age. The collected works of Butcher, I'm getting old enough now that I want to feel that I've made a contribution. Go on, give me a nod. Can you see what that? I want to feel as if I've done something that's, I don't know, remotely useful. And then the other bit, the helicopter shot of the estate, not my noblest of motives, but I've got no desire to be poor. You okay? So, do yours, have a bit of fun with it. And then what you do, so you've got the scene, you unpack the scene in terms of the values, and then you get ethics in a life or ethics in a whole life, because the next question is if that's where I want to be, and this is where I am, how do I get there from here? That's the notion of integrity in a life. How do I put the pieces together so that I can reach, so that I can reasonably hope for that sort of an end of life scene? Does that make sense? Yeah, go on. I've got one nod. So do it with yours. Have a bit of fun. I'm going to do a Lockie story. So Lockie is one of three brothers that are within 3 years of each other. They were sort of bang, bang, bang. They came pretty quickly. And they all played hockey. So if you wanted to find me, it would now be 25 years ago. If you wanted to find me on a Friday morning at 7 o'clock in February, where would you look? Ilderton Arena. So those of you that have had kids that play hockey or have kids, you know what that means. Now, did I want to be at the Ilderton Arena at 7 o'clock on a Friday morning in February? Come on, you should all be saying, no, nobody would want to be at the Ilderton Arena at 7 o'clock on a Friday morning. Nobody would want to do that. But when they came off of the ice, shiny cheeks, big smile, Dad, did you see? Is there anywhere you could possibly rather be? What I'm trying to identify is that if I want that ending, there's stuff we have to do now. That doesn't happen. Yeah, you got to put the pieces together, is what I'm trying to say. So that idea of integrity through a human life, that I think is the stuff of personal ethics. We haven't got it on a slide, but Socrates said that when we're talking about ethics, we're talking about no small matter, but how we should live. That's right. We're talking ethics is fundamentally concerned with what it means to live a life that is worth having, what it is to live a life that allows you at the end of that life to look back on it with some satisfaction. So that's the stuff of ethics. We do it, we live it, and we live it in our professional lives. So if that's the personal side, let me do the sort of the contrast, and I'm going to bring the two pieces back together. We're here, we're doing these sessions because you have professional roles in healthcare organizations. You've got professional ethical obligations that come with your roles. So let me try you. I got a phone call a long time ago, years ago, from a dentist. And the dentist said that he was treating his best friend's son. Fine, right? As part of the workup for the dental surgery, he did some blood work, and it came back showing that the boy, let's make him 15, something like that, that the boy was a really heavy marijuana user. You okay with the setup? And then he said, should I tell his dad? We didn't put this in a poll, but you can put your hands up. Should the dentist tell his best friend that the best friend's son is a dope fiend? I can see one. I can't see a name, but I can see it's Jim. You're not Jim. I know you're not Jim. Yeah, exactly. Jim is saying no. Any other takers? Yeah, go on. What about? I'm getting some no's. I'm getting lots of no's. Any? Yes, you're all no's. You're all dentists. So why are you saying no? You're saying no because he's a dentist, and he got the information about this boy's drug use from, it's privileged. He got that information as part of the healthcare that he's providing. And so the rules of confidentiality say, no, of course you can't tell. Now, just a minute, that is Belinda. Belinda, I'm going to tell you about this. I'm going to go. Oh, and let me say one more thing. When I tell stories here, I will adapt the stories to make it as difficult as possible for you to fudge the outcome. Okay, so when I tell the stories, typically when we're stuck in an ethically challenging situation, is we try and try to make it fit. We try to to deal with the tension, to try to hold both principles together. I'm going to try and tell the stories in such a way that you can't, that you got to choose. So in this story, yeah, go on, tell the boy, look, I'm very worried about your marijuana use. It's clear that I think you should tell your father. If you don't tell your father, I feel that I may be obliged to. To which the boy says, I don't know if you can get that. He says, you've been talking to my dad for years. I've heard you around the dinner table talk about this ethics stuff. If you tell my dad, you have breached my confidential medical record and you're going down. I'm having you in front of the College of Dentists so quick that your head will spin. He's a fairly assertive young boy. So I'm going to try and make it that those fudges don't work. So come back. Most of you, I mean, everything that I saw in the chat flying up. Has anybody said tell, Lockie? No one. I've got no friends. So look, let me do the obligations of professional healthcare. Don't tell. What are the obligations of friendship? Have any of you got friends? Put that a bit. Maybe I should. Anyway, I want to defend the idea. Oh, it does matter. So, what I want to try and capture is that our guy, I'm not going to call him a dentist anymore, our guy has got ethical obligations, moral obligations that come from two different sources. One of them comes from his professional commitments. So he's got a professional commitment not to tell. I totally agree. But he's also got ethical commitments that come because he's a friend. And I would say that the ethical commitment that comes because he's a friend is to tell. And that creates for this person a classic moral dilemma. Now, the conflict of interest piece, I've often heard people say, well, he shouldn't be treating his friend's son in the first place. Yeah, maybe, but he is. So it's a bit late for that now. I mean, that doesn't solve his problem. Whatever he does, he's going to describe himself differently tomorrow, whichever way he chooses. This is a classic dilemma. Two different principles telling him to do two different things. The principles arise from two different sources. He's got to do something. He can't do both. So tomorrow when he wakes up, he's going to end up saying, push comes to shove, I'm a good dentist. It's my professional life. And that's who I am and that's what I do. Or he's going to say, you know what? I'll take my lumps. He's my mate. Got to tell you, mate. Now, is either of those answers for that person wrong? Oh, I've got a better way of putting it. Both of the answers are wrong. And what our guy is stuck choosing is what he takes to be the least wrong. Is that an okay way of putting it? You see, you're all trying to fudge. I made the boy 16. I made him capable of making his own healthcare decisions. And so if you think about the idea that for healthcare consent, you've got to be able to understand and appreciate, the boy clearly is capable of making his own healthcare decisions. He can understand and appreciate what's going on. So he can authorize the release of that information or refuse to release it. Okay, are you okay with the tension? Give me a nod. What I'm trying to capture is that so when I do that bookshelf of books, there's going to be a chapter in one of them on values acquisition. And the theory that I'm working with, I'm calling Rob's bucket of values approach to values and ethics. And it's the idea that we, all of us, acquire our ethical values, our ethical commitments as we go through our lives. We acquire them from a whole bunch of different sources. So in my case, my mum was a pretty active putter of values into my bucket. Okay, very active. That is, at my mother's knee, she was absolutely trying to teach me. No, teach is not strong enough. Instill in me, beat into me a set of values. And then I went to school and I had friendships, and that put values in my bucket. I started engaging in intellectual inquiries, and that put values in the bucket. I took on a profession, and that put values into the bucket. You okay with the idea? It's mostly those values swim around together, and they all do fine together. But sometimes, as in the case that we just identified, two different values come into conflict, and the hero of our story, the person, has got. I was going to use the word tragic, and then I hesitated, but I think I'm going to use it. He's got a tragic decision to make. Whatever he does, he's going to feel that he's done something wrong. Whatever he does, he's going to feel that he's compromised a core value. He's unlucky in that they came into that conflict. All right, but now let me bring them back together. What we're going to be talking about almost exclusively for the rest of the time that we have together over the next few sessions are your professional ethical commitments. And what I'm trying to capture there is the idea that when you took on your professional roles, you took on a series of ethics and values commitments that came with those roles, not the least of which is something like a commitment to your patients. So we can capture that in the language of patient-centered care. That's one way of coming at it. But really, another way of putting it is to say that when we're doing ethical decision-making around things that affect our patients, it ain't about us. It's about them. Can I get a nod there? So that is going to require, and we'll come back to this, we'll revolve around this in a number of different ways. We have to understand who we are. We have to understand what our personal commitments are, and we've got to be prepared to park those when we are acting in our professional roles. Good, I'm getting some thumbs up there. Okay, all right. So, anything anybody wants to chime in with at this stage before we go on? Any comments we should pick up, Lockie?
I think we're okay to move on. I think though that people are still disagreeing with the framing that that he should tell. But yeah, I'm getting some great comments. People are participating, but nothing that I think that needs to be brought up.
Okay. I think I need you to disagree. I think that's part of the point. So, sorry, Arita, can we go back to the last one? So, where do ethical issues crop up in healthcare? I mean, we could have just done one slide anywhere. I sometimes use the phrase from the bedside to the boardroom. We're going to be focusing mostly on ethical issues that arise in patient care. But let me just identify, right up front. We'll pick it up a little bit later on. Your organization faces ethical issues and challenges too, as an organization. So we're sort of mainly focusing on patients, but we'll talk about those organizational pieces as well. So, patient as a person. That's wild if you actually think about the patient as a person. So it's really easy, all too easy. And when you think about the specialization that we have in healthcare, it's all too easy to treat, I don't know, the numbers on the screen, to treat the disease, I was doing some stuff with, there's a group called Common Sense Oncology, and that group says roughly, bottom line, cancer care is often provided for too long, to too little good effect, at too much expense. So that is a whole bunch of cancer care is delivered to people beyond the point of there being any return that's worth having. Okay, so we can quibble about the details, but that's that's what this group is arguing. Common Sense Oncology. But what do oncologists treat? Do they treat cancer or people? I need a pause. And you can see the point, though. When I ask the question like that, people, yes, maybe. But what I'm trying to identify is you might get different answers about what you should do if you think about the person as a person or if you think about the cancer. So that is, you might do things to treat the cancer that don't have any impact or even a negative impact on the person. So we'll probably get to it somewhere later on. I've got some slides on some stuff from I think it started in Scotland, and it says the idea is the question we should ask is what matters to you. So rather than asking what's the matter, but ask what matters to you, because what that good. Yeah, you should look at the chat if you can have it on the side of your screen, because what we're talking about is what it would actually mean to think about the person as a person in the context of their healthcare needs. And what I'm trying to do is to put the healthcare needs into the context of a person. We'll come back to that. We'll repeatedly come back to that idea. But we're not just talking about an individual. Well, are we? I don't know. Here's what I'm trying to capture as a challenge here. Those individuals are often enmeshed in family groups. What difference does that make? So if you think about the Healthcare Consent Act, and we'll talk in way more detail about that in future sessions, that's all about the patient. I don't think it says anything about families. And so, of course, what I'm trying to capture is how much difference does it make? What difference should it make to think about the person as an individual, to think about the person as part of a connected entity, a family? We'll talk a little bit about that when we do some moral theory in a bit. The patient-centered care, what I'm after there, everybody uses the language of patient-centered care, but I think it creates a false impression. It creates the impression, what it's intended to say is, here's the patient, can't see my hands, I can see my hands, here's the patient in the center, and then there's this entire team that wraps around that individual, and they're all focused on them. Yes, but that team is also wrapped around the patient in the next bed and the patient in the next room. And if we go a little further on, somebody's got to be thinking about the patient that hasn't yet got in through the emergency department, because we're so focused on the patient in front of us that we haven't worked out that that person maybe should be moving on to make space for the next person to come in. So my worry about patient-centered care is the idea that I don't think it doesn't capture the fact that every patient is at the center of our care. And sometimes the things that different patients need come into conflict with each other. Excuse me. All right, let's go on. So we started by thinking about where do ethical issues arise in the healthcare setting. They arise because we're dealing with people, with patients, but you're also coming at this as professionals. So there are a whole bunch of rules, ethical principles that govern the things that you can do as a particular healthcare professional. So how does that work? What I'm trying to say there is patient-centered care, yes, but there are limits on the things that you can do for your patient or with your patient, limits that are created by your professional practice. I won't get the details of the example right, but maybe 15 years ago, I don't know, there was a so-called experimental treatment for, I can't remember if it was a cancer or if it was for a neurological disorder, but a debilitating disorder that did not have a gold standard treatment available in North America. But there was a guy in Italy, I think it was called liberation therapy, I don't know, doing something that was experimental and that some people said was bringing a benefit to them. So there were a whole bunch of stories here in Ontario of people selling everything that they had. They sold they sold their houses, they cashed the money in, and they went to Italy to have liberation therapy from this a physician. And somewhere in there, I heard interviewed a Canadian physician who said, "Look, I know what this guy's doing. I mean, I know what the procedure is, and I can do it here. You don't have to go to Italy." So at the time, what I want to suggest is that that physician should not have been offering that treatment. That is, it's an untested, unproven, not evidence-based intervention. And I would argue that that physician's professional standards should prevent him from offering that intervention. You don't have to agree with me. I just want you to try and capture the idea that there are limits on the things that you can do as a professional. That those professional boundaries are there that prevent you from doing some things that people may very well want. You're also colleagues. So people use the language of team-based care. Having said that, what do physicians write? Are they requests? Would you be good enough to? No, physicians write orders. That's a very particular word. It's a do this. It's an order, and it's an order that comes with authority. So how does that work in a team-based environment? It's the physician that writes the orders, but there are many people who may well be far closer to the patient than may know the patient far better than the physician. How do we share decision making? Maybe that's the way I want to put that. How does that work for colleagues? And then you're parts of organizations, of institutions, and you have commitments to them too. Can we go on, please? Now think about organizations, think about your organizations. Priority setting and resource allocation are ethically rich activities. So in a zero-sum game, you got your pie. If you give a slice of pie here, that slice of pie is not available for somebody else. And healthcare is pretty much, in a publicly funded system, a zero-sum game. So that means that any priority that we follow means that we leave a whole load of stuff undone. So the bottom line here is we better be certain about what we're doing and why we're doing it. I've done a couple of sessions fairly recently with hospitals in the north of Ontario, where there is incredible competition for emergency room physicians. So in order to keep the emergency department open, you need people to come in from away, come in from outside. And the incentives that get kicked around in order to entice people to come in and fill those shifts to keep the emergency department open, quite extraordinary. And what they mean is that the ED physician here, who's flown in from somewhere else for a couple of shifts, is often getting paid dramatically more than the emergency department physician over here, who's a family doc in the local community and is committed to providing care where he lives. Is that fair? What don't we do if we're busy shoveling money at people to get them to fly in? What doesn't get done elsewhere, including better recompensing the people in the community who are prepared to do that work as a commitment to the place in which they live? Okay, we can go on, please. So again, I'm just stuck with thinking about organizations and the way in which they express their ethical values. I told you I'm going to Bracebridge tomorrow. I mean, a year or so ago, I was in Bracebridge and we were talking about this topic, relations with other organizations. And we were talking about donations, about the charitable foundations that many hospitals have and that funnel money for good work from the community into the hospital. And partway through, somebody said, "Rob, do you know what our emergency department is called?" Of course, I don't. I can't remember the name, but it's somebody's name, family name, above the emergency department. I said, "Okay," and they told me what it was. They said, "Do you know where they made their money?" I have no idea. They're the family that founded the website called Ashley Madison. I can't see your faces. Somebody is smiling. Somebody knows what Ashley Madison is. And those of you that are not smiling are pretending you don't know. Ashley Madison was a website. Yeah, exactly. Good. I like the emoji things that are coming up. Ashley Madison, their website, the motto was "Life is short, have an affair." I guess it made a lot of money, enough that they could name the emergency department in that hospital. Is that a good thing? I don't need an answer. I just need a sort of puzzle. Okay, we can go on to the next one. I'm going to skim through this fairly quickly because I do want to do a little bit of moral theory to finish. Moral problems. Look, I've been using moral and ethical pretty much interchangeably. I'll always do that. I think in their essence, they mean the same thing. Sometimes people talk about professional ethics and personal morality. I think our dentist story separated those two, but brought them back together. I mean, at the end of the day, it's one person, and that person has to make a decision. And whether those values, principles, whether they were acquired through the person's professional life or through their personal life, I don't think makes any real difference. They're still my values, and I still have to make a choice. So moral problems don't come with a label. I'm talking about cues here, and the cues that I'm after are harm, fairness, and conflict. So we can go quickly to the next one. So here, this I'm going to make a strong claim about ethics. If the thing that we are talking about entails a harm, and that might be physical, psychological, financial, any of those, if the action causes a harm, entails a harm, then we have to think about that action in ethical terms. I haven't yet said that we should or should not do it. I just want to say that if there's a harm involved, it's in the domain, in the territory of ethics. So harm is a strong indicator, an infallible indicator that the thing we're talking about is in the moral domain, is in the realm of ethics. So that means if we're going to do it, we're going to have to be able to explain why we can do it. It's going to need, to use the language of ethics, a justification. Does that make sense? So, it doesn't mean we shouldn't do it. It just means we're going to have to explain in ethical terms why it's okay to do it. In healthcare, that's consent. So the whole grounding of consent is this. It's the idea that a whole bunch of the things that you do cause harms. The laying on of hands, the touching, is an impingement on my sense of self. It's a harm. If you did it on the street, that can be called a tort. There are rules that govern that, but it's okay for you to do it in a healthcare context because the person has said it's okay. Right, the consent piece. Okay, we can go to the next one. You can think about that. Yeah, I told you I was doing the long-term care session today. We did some stories that we're going to pick up later on. We'll do them when we do our sort of end of life stuff, I think. But a number of the conversations concerned what counts as a harm. So we're going to do Eric and the meatballs in a bit. The teaser for Eric and the meatballs is that Eric is a vegan who has taken, and he has some dementia in a long-term care home, and he's taken a strong liking for real meatballs. And should he be allowed to eat them? Part of that puzzle revolves around what counts as a harm to Eric. So you could say Eric is harmed because he can't have what he wants, real meatballs. Or you could say Eric would be harmed if he was allowed to have the meatballs, because that's contrary to his lifelong sense of who he was. You don't have, we'll unpack it in more detail. I just want to capture the idea that harm seems like a transparent notion, but I don't think it is. We're going to have to do a lot more work to work out whether a particular something for a particular individual is a harm. So we'll come to that. And then there's the matter of the influence that identifying something as a harm has on deciding what we're going to do next. Okay, we can go on to the next one. Fairness. So I told you Locke is one of three brothers that came fairly quickly one after the other. I think that the first words that Locke is the youngest, that his older, the middle brother, first words he said as he popped out of the womb were, "That's not fair." Go on, you should get a smile. Somebody should give me a smile. I called it a primitive moral judgment. The idea here is that our sense of fairness, I don't know, it's primitive. It's right in there. Kids have got a fantastic sense of what they take to be fair or not fair, more to the point. It's an appeal to justice, just to give it a fancier name. And the decision that this or that is or is not fair is a moral judgment. So if it's an issue of fairness, it's in the moral domain. So that's another cue. Okay, we can go on to the next one. Conflict. I've called this a weaker indicator. Here the idea is often, the reason that we're thinking about it, considering, is because there's a conflict. But not every conflict is a moral conflict or an ethical conflict. Sometimes they are. So sometimes what forces it into our sort of perceptual frame is that there's a conflict involved. And then what you're trying to do is to unpack the conflict to try to identify whether there's an ethical component to that. Okay, we could go on. Yeah, we can do the word cloud. How would you spot an ethical issue? If you were going to give people a cheat sheet, if you were going to do the education piece in your organization, spotting moral problems, ethical issues, what word would you use to try to flag for people that they should have their ethics spidey senses up? So go on, you can throw some things in there and we can go on to the next one. And Lockie, you're going to have a look at those and you're going to jump in a bit. Ethics is a big deal. That's what this slide says. We are, all of us, completely committed to our own moral values, our own ethical principles. Can I buy you out of your moral principles? And the answer is going to be no. I mean, what I'm trying to capture is the idea that we take those to be sacrosanct, hugely significant. We're coming at this by working from our personal commitment to our ethical values. We're connecting that to the way in which we acquire values as part of our professional lives. But we care about this stuff. We care about it deeply. Now, the ongoing commitment, the ongoing evaluation. Yes. So one of the points of all of the sessions that we're doing over the next few weeks is to try to prompt that ethical reflection. So we all come at, we all come at all of these pretty much unthinkingly. It's just what we feel. When we unpack the stories, we're going to try and unpack the feelings. So we're going to try and look at the way in which our moral feelings have got a connection to moral ideas. So what's the relationship between the feeling and the idea that goes with it? So absolutely, we're going to be talking about that. Let me just give you a classic example. 1 minute before the MAID legislation came into practice, if a nurse practitioner had given a lethal dose of a narcotic to a patient with the intention of killing that patient, that nurse practitioner would have committed murder. You okay with that? 1 minute after the legislation came into practice, if that nurse practitioner did exactly the same thing, provided she dotted all the I's, crossed all the T's, got all the consents and all of that stuff, what she had done would be described as good patient care. Same act, same intention, but the legislation changed, which meant that our, well, I was going to say our moral evaluation of the act changed. Maybe it didn't change, but what happened is the law caught up with the moral evaluation. We'll unpack that later, but what I'm after is the idea that the Carter case used the principle of autonomy from Section 7 of the Charter, the right to life idea, to become a right to have somebody help you die, which was just a really, really interesting way of reasoning to a different conclusion. So I didn't see who put up that sort of constant reflection idea, but absolutely yes, that's what we're going to try and do over the next few weeks. We got the next one. Yeah, keep going, please.
Just while you're moving through there, I'll just say some of the results of the poll. Some of the common things that we saw were conflict, distress, discomfort. I find when I'm having conversations with healthcare providers, typically my prompt would be things that make you feel uncomfortable, that don't sit quite right, that bring about that distress. I find that those are the most salient. They're the ones that really spring to the surface the fastest.
Some people use the ick factor. I don't think ick is quite right, but ooh is a better one. It's those stories, those cases that make you go, oh, I'm not sure about that. And then the reflection piece is to try to understand why I have that reaction. Okay, so it's, and what that's capturing is that when we're talking about ethics, talking about morality, we're not just talking about reason. There's an emotional component to our ethical lives, which is absolutely connected to the cognitive component. but it's often the emotional bit, the ooh reaction that comes first. And then what we've got to do is try and ground that, try to understand and determine whether it's appropriate. Because we can have an ooh reaction to stuff when we think about it a bit more deeply, we can realize that that reaction is misplaced. So that's the reflective piece. Okay, messiness of morality. The picture I'm going to try and paint is one that says our moral lives are complex, complicated, and in tension for all sorts of different reasons. That is, there isn't a hierarchy of ethical principles. There isn't a formula that we can use where we plug in the rules and generate a right answer. It's way messier than that. And what we're doing when we do what we typically call as ethical decision making is we're making choices. We're making choices to do this rather than that, and we're making those choices based in reasons. So messiness of morality, conflict between the principles. The rules sometimes give you different answers. We'll do some examples of that in a bit, but we'll see it all throughout. There's conflict between people. So if you think about scarce resources and access to those scarce resources. I need it, you need it, there's only one of them. There's a conflict between persons as we try to get access to that thing that we both need. If you think about ethics in terms of rules, there's the general conceptual puzzle about whether the rule applies. So we're probably all going to agree that you shouldn't murder. I should get a nod. Don't murder. Is made murder? No, you should be saying no, it's not. But opponents of made will say it's an intentional killing. Therefore, it's a murder. Well, so what we're getting at is, does that rule, thou shalt not murder, apply to the intentional killings that are associated with medical aid in dying? The foes of abortion will say that abortion is murder. Well, okay, we're going to come back to it. So, all right, can you see the problem? We've got a rule, and there's a whole series of puzzles, inevitably, for any rule, about whether the rule applies in some particular situation. So we're going to have to make, I've used the word judgments here, decisions. Again, you can use any of those words. It's just not fixed. It's not clear, and we're going to have to work our way through it. We can go to the next one. This is just to say that the hierarchy doesn't work. There isn't a hierarchy. Should you save a life where you can? Moral principle. You should all say yes. Should you keep your promises? Yes, you should all be saying. What happens if, in order to save a life, you've got to break a promise? Is saving lives a more important ethical principle than keeping promises? Go on, that's a real question. You can think about. Look, what you should be. It depends. Lindsay's a philosopher. Yeah, it does depend. Actually, it depends what the promise is. But again, what I'm sort of trying to tempt you with is a sort of a simple hierarchy. Well, of course, saving lives is more important than keeping mere promises. Well, not always. If your promise was to a member of the Jehovah's Witness tradition that you would not give them blood or blood products, you would let them die rather than save their lives because you made the promise. So, yeah, all I'm after, you're right, you've got it. There isn't a straightforward hierarchy of moral principles. So we've got to make some judgments. We could carry on, please. Yeah, let's keep going. Same idea. Let me do, so this is unpacking that conflicts between persons. We're going to explore this again a little bit more. What happens if we're trying to do what's best and the benefit comes to me, but the cost goes to you? So overall, it's better that it turns out it's better that I get it and that you don't. Or you could do it. It's better that two people get it and one person doesn't. How do you balance a benefit to me against a harm to you? So that's, you know, a puzzle. Group and individual interests. Let me pick that idea up. That's COVID throughout. So that's public health. Under what circumstances should an individual be required to do something that they don't want to do for the benefit of the entire community? Measles vaccination is a, you know, classic example. So what are that's the contest between individual rights and group rights. Again, stuck with having to make ethical decisions. We could go on. This is cheery. Sometimes it's all bad. In fact, in many of the cases that we're talking about, it's all bad. That is, whatever you do is bad. And what we're trying to do, I use least bad, least worst. What we're trying to do is find the best available under the circumstances. But it might be that the best available is itself bad. Go back to our poor guy, who is also a dentist. He's going to compromise a principle that he holds dear, whatever he does. Whatever he does is bad from his perspective. We've called this tragedy. It's the classic sort of moral dilemma idea. We could go on. So ethics is not law, ethics is not religion. And maybe the way of capturing that is to say that, you know, for any law that you could identify, you can ask yourself whether that's a morally good law, and you can do exactly the same for any aspect of a religious tradition. You can hold up the elements of the religious tradition, you can hold up the laws that we have and evaluate them on ethical grounds. Yeah, let's keep going. I was almost going to do some Plato for a minute, but I don't think we will. Maybe we'll come back to it another time. Let's just keep going. Yeah, so let me do this. We're going to do 2,000 years of moral philosophy in 14 minutes. And maybe we'll pick some of it up next time, but I just want to throw a whole load of ideas at you. The ethical traditions, the moral traditions that we're going to look at, are all of them trying to answer the question, what makes a right act right? That's the foundational question in moral philosophy. What counts as a reason for doing this or for not doing this, as opposed to doing that? And all of the traditions that we're going to look at are attempts to answer that question. So we're going to go really quickly through this. We could go to the next one. We're going to look at the Greeks, Kant, Mill, Hobbes, Ross, and we'll finish with a really quick discussion of a feminist approach. Okay, we could go on. So you'll get my biases. I think that the Greek approach to ethics, the ancient Greek approach to moral philosophy, that's back to that Socratic idea. We're talking about no small matter, but how we should live. The Greeks answered that question by saying, the well-lived and flourishing human life, eudaimonia, consists of a life that is lived in accordance with the virtues. And the cardinal virtues are justice, wisdom, courage, and self-control. So I think that's all true. That is, I think if you're teaching your kids, if you can instill in them the idea that they are really likely to have a good and worthwhile life if they exhibit the virtues of justice, wisdom, courage, and self-control, I think you would have done them a great gift, or given them a great gift. I think this is constitutive of good lives. Yeah. All right. So let me just throw it out there. You can think about that. And the other thing I think I'll say is that's 2,500 years of in the past, that stuff. And I'm prepared to defend it. Some of the others virtues maybe not so much. I'm skipping forward, I don't know, it's set to about the 1700s. Um, the Kantian approach, I'm going to pick up some pieces that I think have a profound impact on the way we think about ethics now. So in the interim, between that Greek approach and Kant, there's the dominance of the Judeo-Christian tradition. So if you think about the way the Judeo-Christian tradition approaches ethics, it approaches it in the form of a whole bunch of rules, the 10 Commandments, a whole bunch of thou shalt nots. Now, in order for there to be thou shalt not, in order for there to be commandments, there's got to be a commander. There's got to be an authority figure that lays down those rules. What Kant does after the Enlightenment is says, okay, well, we can't have God being the lawgiver, but ethics is moral law. So what's the grounding for it? And he wanted to ground ethics in reason. So it's called a deontological approach. It looks at duties. What he said is that our ethical obligations are unconditionally binding. If you've got an obligation to keep a promise, you've got an obligation to keep a promise. Universal, everybody's got an obligation to keep a promise. He's also going to defend the autonomy idea. I think I've got a quotation from Kant next, have I? Yeah, let me do this. So his general idea is think about the thing that you're proposing to do, and then turn doing it into a rule that applies to everybody. It's the what if everybody did that approach to ethics, right? Can you still will it and will that everybody did it in the same circumstances? The second quotation, though, is I think a bit more interesting. I think this is the foundation for the consent doctrine in healthcare. Act so that you treat humanity, whether in your own person or in that of another, always as an end and never as a means only. So what Kant identified is that the wild thing about being a person is that you get to make yourself up as you go along. You get to create who you are. In his language, you set your objectives. You are an ends maker. You okay with this? It's you decided that you were going to follow the career that you ended up following. You decided the relationships that you engage in. You decided what you had for breakfast. you create your objectives, your ends. Excuse me. That's what it is to be a person. Well, if that's true, if you're an ends maker and I'm an ends maker, then logically I can't use you for an objective of mine. Does that make sense? Because then I'm treating you as a thing. I've misunderstood what you are. You're a person, you get to choose who you are. I'm a person, I get to choose who I am. I can't treat you as, logically, I can't treat you as something that you're not, to treat you as an object. I think that's a fantastic idea. And I think it ends up being the underpinning for the doctrine of consent in healthcare. Okay, let's keep going. The standard contrast in ethics is between Kant and Mill. What Mill said, it's a Mill utilitarianism, Mill's idea is, look, we can work out what we should do by looking at what brings the best results. So if you like, Kant is sort of a rights-based approach, and Mill is a consequences type approach. So, greatest happiness principle, the ultimate end are things which are desirable. Whether we're considering our own good or the good of other people, the thing that's desirable is an existence exempt as far as possible from pain and as rich as possible in enjoyment. So I think we can go to the next one. Actions are right in proportion as they tend to promote happiness, and wrong as they tend to produce the reverse of happiness. By happiness is intended or meant pleasure and the absence of pain. By unhappiness, pain and the privation of pleasure. Core idea is you look at the consequences. Let me give you the Kant and Mill difference using a COVID example. So in COVID, we got perilously close to a situation where there were way more people who needed access to ventilators than there would be ventilators available. So we were really, really close. Two fundamentally different ways of trying to work out who gets ventilators. So one approach would be to say something like everybody who meets the criteria is criteria that one would normally meet for access to a ventilator. Anybody who meets those clinical criteria is equal. And if there are 3 people who meet the clinical criteria and there's only one ventilator, then what we've got to do is something like draw lots. They've each got an equal claim by right to access to that scarce resource. It makes sense? Sort of a rights-based approach. First come, first served is what we do through much of healthcare. An alternative approach would say, look, let's use the ventilators to get the best result. So instead of thinking about who's entitled to it, think, how can we do the most good? How can we save the most lives? And then what you do is you set up a series of clinical criteria that reserve the ventilators for the people who are most likely to benefit. So instead of giving it to somebody who, has got a 50% chance of benefiting, let's give it to somebody who's got an 80% chance of it benefiting. And then you can do more good. You're more likely to save more lives. You okay with the difference in answers? We often operate in healthcare on that Kantian first come, first served, everybody's equally entitled, we've all got a right of access. We often work that way, but sometimes, and I think in particular in public health, what we're trying to do is maximize the good. So Dalia was pointing out that, so there was a critical care table that was developing a whole series of criteria that were exactly intended to maximize the good that could come from the use of those scarce ventilators. And as the scarcity increased, the likelihood that you would benefit, the requirement that the likelihood that you would benefit went up. So fewer and fewer people would get access because there were fewer and fewer beds, but it would go to the people who are most likely to benefit. Okay, let's keep going. We can finish this. We've got 4 minutes. We can do it. Oh, here we go. We did this as a poll. You might as well put it in there. If you were the ventilator assigner, would you try to do the most good, or would you, I don't know, do the right thing, whatever the consequences? Are you a consequentialist or a deontologist, to use the long words? Would you go with doing what's best or doing what's fair? Would be another way of putting it. Okay, we'll see what people say. Okay, let's go on the next one. Okay, so you won't get people when we're done tonight, but so what Hobbes said, you can quote this. Hobbes said that life in the state of nature is solitary, poor, nasty, brutish, and short. So that's a phrase that you might want to sort of memorize for use at dinner parties. What Hobbes said is, imagine what it would be like if we were all of us simply self-interested. So imagine that the state of nature is that all of us just do whatever we think we can get away with, whatever we think is in our best interest. We may have some examples of that south of the border. But imagine, What Hobbes said is if everybody did that, life would be solitary, poor, nasty, brutish, and short. If it's the war of all against all, if I've got to defend everything that's mine against everybody else, I'm going to spend my whole life in this vain attempt to protect the things that are mine. Way better, said Hobbes, that we come to agreements. I'll tell you what, I won't take your stuff and you'll promise not to take mine. Deal. And then expand that. So the Hobbesian idea around the grounding of ethics is that it's grounded in agreements that we create in order that we can get on with each other, in order that we can get on with living our lives. Okay, so it's all by agreement. Let's go to the next one. But you have to keep your agreements. People don't always do that either. Ross just tried to capture the idea that, oh gosh, we've got all these principles that come into conflict, and it's a mess. So let's go to the next one. I'm going to finish with this. Are you going to give me 2 more minutes? Because you can think about this until next week. Give me plenty to think about. This is, relatively speaking, contemporary. So Gilligan and Noddings were writing in the late 70s and early 80s. They both of them defended an idea that they called an ethic of care. So they said, oh, look here, don't ask what a person is entitled to, sort of a rights-based approach, but rather ask about what they need. Does that? And what Noddings said is that all of ethics is grounded in the mum-baby relationship. That's where ethics comes from. So Gilligan was Gilligan was a psychologist, and she was working with a psychologist whose name I've lost right now, who was doing developmental stages in moral psychology. So in the research that was being done, the researcher, and it's going to bug me because I've forgotten his name, had a series of developmental stages for ethics, and he discovered that the sort of top levels, either 4 or 7, depending on which version of his work you read, he discovered that women rarely reach the pinnacle levels of moral development. Now, I said that slowly and I did a pause at the end. You should be thinking, he thought, oh gosh, that's interesting. And his student Gilligan thought, if that's the answer, then the question is wrong. Good for her. And her approach was to unpack the sorts of research that was going on in terms of what she described as the developmental tasks of boys and girls. So she argued at the time, maybe it's different now, but she argued at the time that the moral or the developmental task for boys was individuation and separation. I've got to work out who I am, separate myself off from my family, strike out and go west, and then create my own family. And she argued that the developmental task for girls was one that required the maintaining of networks and connections, broadening webs of interconnection, rather than that separation individuation piece. And she had a whole load of lovely little experiments where she would ask people, what they would do, and got radically different answers from the boys and from the girls. The boys wanted to know what was mine, and they wanted to be able to control it. And the girls wanted to remain connected. They wanted to find a way of working together and moving forward. So those feminist approaches, are really oversimplified, but they fundamentally challenge what it is to be a person. All of the men that we saw beforehand took for granted that the locus of decision making is you, the individual, me. What's mine? What am I entitled to? How do I interact in a fair way with the people around me? That's the male approach to ethics. What Gilligan and Noddings argued was that doesn't capture where we live, and that what we have to do is recognize that people are fundamentally connected in all sorts of profound ways, which has a huge effect on the things that they subsequently do. They absolutely argued, look at the lived experience of the people concerned and look at power relations, follow the money. And that will tell you an awful lot about what's happening in ethics and the rules that we have to divide things up. And maybe that will take us right back to the story that we started with around reconciliation and indigenous power relationships, and the way in which the challenge is to give up that power-oriented, what's mine, what's yours, let's adjudicate who's in the right in this particular situation, give that up and try to find something that remains connected. All right, I've done enough. Sorry, we weren't, no, I'm not doing rights. I'm done with rights. This is it, I'm finished. Has anybody got a final comment? Everybody's finished. Well, then think about this stuff and come back next week and we will, oh, well, here. So what have we got? Are we doing the certificates weekly or at the end of the thing already? I don't know.
We can do weekly because some people might want to
Sure.
do it, but we can do one for at the end of the session if that's how it is required. We'll follow how people want it to be done.
All right, so let me just identify that we for certain are happy to provide certificates of participation. We're glad you're here. We'll do an evaluation somewhere. Have we got an evaluation for this, or are we doing it at the end? I can't remember.
Yes, there is evaluation for this as well, and
all right.
It can
so
be
look,
so the two QR codes are, one is evaluation, the other one is
yeah,
just requests for certificates. Yeah.
Okay. Put your comments in the chat. Thanks for sticking with us, and we'll try and be more conversational next time. Have a fantastic week.